Good evening all to the 113th session of the weekly huddle. The shallow attendance today is a reflective of our discomfort addressing difficult topics like the one that we have chosen today. I myself was not quite sure about how to bring this topic up and how to engage in a discussion. So for this particular session, I actually modified a clinical case quite heavily. As you all know, most of the time when I present a clinical case for discussion, those are the usual clinical cases that we see in our practice. This particular case, I just kind of modified a little bit so that it suits today's discussion. We are talking about polypharmacy, we are talking about de-prescribing. None of these topics are something that we are categorically taught about in our medical school, or we are categorically instructed on how to deal with in our early practice. While these are less discussed and less comfortable topics in the current era where we are defining new diseases and we are identifying new ways of treating them, while we are not skipping, or why we are not parting away from our earlier practices, that just kind of keeps adding burden to individual patients. There are two aspects of today's discussion. One is inappropriate prescribing or inappropriate drug. Something like a patient with hypertension being given routine NSAIDs. Now that is something that we identify as probably incorrect practice, or probably scientifically non-validated practice. There, the decision making is not that complicated. We are talking about, or I want to emphasize in today's discussion, those prescription patterns or those treatment patterns, be it medication, be it procedures or whatnot, but for today's discussion, we're limited to medications, where there is a proper indication, where if you go by the scientific data, one may argue that there is a rational indication of putting this medicine. But that seems rational when we focus on that particular ailment and that particular scenario. But when we fit it into a given patient, and we put it into the patient's overall profile, age, other comorbidities, their life expectancy, patient preferences, not just evidence-based, but also what you would call it as patient-based, then we start realizing that a lot of the times what we are trying to achieve may not necessarily be what patient wants, may not necessarily be in the best interest of the patient. We all know that while the drugs that we prescribe, they are extensively tested in the randomized trials or phase 3 and phase 4 trials. What we do not know is how do these drugs behave when a person is taking more than 4 unrelated drugs together. Their science has absolutely no clue in terms of how the drug interaction works. So that is what I'm trying to address today. Polypharmacy in a given context where apparently the drugs are indicated to a patient to achieve what, that also we want to discuss. But more so, even when it is scientifically validated, is it something that we should go ahead with? Is it something that can be justified in these kind of patient subset? So the clinical case I have already shared on the WhatsApp group. I'm going to read it out. It's a long case, so I'm going to quickly browse through it. If any one of you want to know the details of it, you can please open the WhatsApp group and the case details are there. So it's a 76-year-old male. He has a previous history of coronary artery disease. About 4 years back, he was admitted with non-ST elevation MI. At that time, he had cardiogenic shock, was intubated because of heart failure. An urgent PTCA was done to LAD and RCA, after which he recovered quite reasonably. During his cardiogenic shock, he also had some mental status issue, which led to prolonged intubation And there was some doubt about whether he had a stroke or not. An MRI was done, which showed multiple areas of watershed infarct, for which neurologist was consultant, and neurology put them on some preventive therapy. He spent a long time in the hospital, after which he was discharged, and since then he made reasonable recovery. So that was around 3.5, 4 years ago. He also has diabetes going back around 15 years back, for which he's taking multiple medications, including insulin. His most recent A1C was 7.6, which says that he is reasonably controlled. He has chronic kidney disease with his baseline creatinine hovering around 1.3 to 1.5, and this also can be traced back to the index admission. He has a diagnosis of COPD, which I couldn't trace how the diagnosis was made, but he had seen a pulmonologist a couple of years ago. And since then, he had been on inhalers, which he takes quite regularly, and he says he feels fine. He also has a history of BPH. His recent PSA was 2.4. The last time he met a urologist, again, was a couple of years ago. His most recent ultrasound suggests grade 1 prostatomegaly. His symptoms are reasonably controlled. He also has osteoarthritis, which seems to be a little bit more dominant symptom for him. But because he's not that active, he seemed to have come to terms with it. He's not interested in knee replacement. So this particular visit, he has no active complaints. He's reasonably active for his given age of 76. He has got a soft ejection systolic murmur. A recent echo was done, which showed aortic sclerosis, but no aortic stenosis. His ejection fraction was noted to be 45%, which with the distal anterior wall hypokinesia. On his examination, there is no any evidence of fluid overload. His blood pressure in the visit was 112/68. With a heart rate of 62 on ECG, it was shown to be sinus rhythm. So there is a list of medications that he's currently on now. I'll give you a little bit of background. He is a CGHS beneficiary. So all of the medication that he gets it from the dispensary. And there are multiple providers who are writing medications for him. I won't tell you the doses and stuff. It will be too long. I'm just telling you the names of it. So he's taking aspirin, clopidogrel, atorvastatin, telmisartan, metoprolol, longer-acting nitrate, metformin, dapagliflozin, voglibose, vildagliptin, mixed-ard insulin twice daily. He takes inhalers, Foracort, tablet, AB-filin. He takes Silodol D, which is silodocin plus dutasteride, levetiracetam, and nootropic, which was started 4 years back during his admission, and since then it has been continued. He early on was at a higher dose of levetiracetam, and for the past, I believe, a year or two, he's taking 500 twice daily. He's on multivitamin, Neurobion 4, Trio 60K, which he takes once in a month. And then he's on a few prescriptions prescribed by orthopedician. One is glucosamine, what you call extract or concentrate. That's a capsule, and then he takes one Tendo Pro capsule, which is again some extract capsule, which is supposed to help with his osteoarthritis. He takes pantoprazole because now he's on all these drugs. For his CKD, he takes Nodosis 500 milligrams, and he takes Celprotic, both of which has been prescribed by his nephrologist. So the discussion points that I have for today is, in your opinion, what constitutes a polypharmacy? Is this patient somebody who would qualify for a polypharmacy? Is polypharmacy restricted as a definition only to those patients who are getting inappropriate therapy, or those patients who are getting appropriate therapy, but there are just too many of them? Then the question is, how do we strategize to minimize polypharmacy without putting these patients at risk for clinical events? How do we manage de-prescribing, which is very, very challenging in my opinion? Writing prescriptions is very easy, but when this patient goes to some other doctor, that other doctor may not have that conviction or the confidence to de-prescribe the medicine that I have prescribed, and vice versa. And lastly, in this particular patient subset, how do we do medical reconciliation, understanding that this patient do not have like a primary care provider? And as we all understand in India, to a lot of our patients, there is no primary care provider. They just go to various specialties. He sees 4 specialties. He sees cardiologists, nephrologists, neuro, and orthopedics. And for the sake of primary care physician, he sees his CGHS doctor, but what I have seen over the time is, at least in his case, the CGHS doctor is just forwarding the prescriptions which are written by the specialist. So I'm sure none of these specialists would pick up the tab of doing medical reconciliation of all other specialities. So how do we manage these kind of situations? Now, we can't have an ideal world. That is something which is difficult. We can't, at the blink of an eye, have a geriatrician managing all these patients. That is not available in India. That is something which is impractical for us to expect. Or maybe you guys can correct me if I'm wrong. So all these things are there. We are talking about polypharmacy and how do we handle this. So I'll start the discussion asking Praneet for his opinion, and then I will take opinion of other members. And since we have a little bit of shallow attendance today, maybe I'll just ask each one of you for your opinion about this case. So Praneet, all yours.
Yeah, no. I think this we discussed before we posted about this discussion. Polypharmacy we keep discussing in our previous huddles as well, and I thought and we thought discussing this. I will share my thoughts on polypharmacy. In my opinion, polypharmacy to begin with has reduces the compliance of the patient. Very few patients are fond of taking these tablets, but majority they have an issue. The challenge also occurs when multiple specialists are visited. That is one reason where if a person meets several of these specialists, then the drugs kind of add piling up, and there is no proper person, like what you are saying, as a primary physician who kind of checks this thing and who kind of consolidates. Sometimes there is multiplication of the same drug, and sometimes there is the addition of these unnecessary drugs which keeps piling up. The other problem that happens is most of the times, particularly with these credit patients, what we call, is that sometimes these drugs are not available as a combination. They are only available as individual. I posted one of the prescription which in the weekly huddle WhatsApp, one of the prescription of my patient, where again, if you look into it, there's a whole list of medication. This patient I've been following for quite some time, and these are the standard medications which the patient insists me to write, because unless I write all those drugs, the central government health scheme dispensary does not dispense these drugs. So this is almost a standard prescription for her. Some modification here and there, but majority of the drugs are constant for the last 6 months or so. So that is one challenge where these patients are dependent. When you try to make them as a combination, reducing the pill burden, it is not possible because the dispensary does not give. And sometimes these other medications are added up from the patient point of view and also from the physician point of view. These so-called vitamin supplements or strength supplements which patient asks, and some calcium supplements which they feel to improve the strength of the bones. Most of them, I believe, work as placebo, and very few have few indications to actually supplement these things. Or even if we supplement, then the duration should be of a shorter duration. But that again kind of gets uncorrected, and the prescription kind of continues. So there is a problem from both the patient end and I believe from the physician end. One, because we do not pay much attention to whether these drugs are really indicated or not, and maybe doing a cross check with the busy practice, we may overcorrect, and with the rush to clear off the patient, we tend to miss these things, and this gets corrected. In the index patient, I believe there is a lot that we can get corrected for a 76-year-old person who recovered from an acute coronary syndrome and who is relatively stable now after 4 years. We can kind of reduce most of this medication, and we can cut down a lot. So starting from dual antiplatelet therapy, we can cut down to single antiplatelet therapy. and the combination of statin and antiplatelet can be made where the pill burden can be reduced. His LV dysfunction is still there, so beta blocker is indicated, and the beta blocker and telmisartan probably can be made into a combination, again reducing the pill burden. He does not seem to be having any angina, so I think the nitrates can be cut down, and the drugs for his insulin again can be probably combined, where again the pill burden can be reduced. The role of epiphylline, I am not completely confident, but the inhalational bronchodilators are effective enough in managing bronchial asthma. So I think epiphylline can be cut down. Solidol D for his prostate should probably be continued. Levetiracetam for the seizure prophylaxis, I believe, is not indicated now. So is Neutropil, which probably can be cut down. Neurobion is a multivitamin. Again, if the patient is not a vegetarian, we can probably cut down. Tio 60K is only a supplement. We can again reduce it, and other drugs and all can be reduced and can be. We can ask him to do an active physiotherapy. So most of the drugs, in my opinion, can be cut down. The problem is getting the confidence of the patient as well, where these drugs, the two challenges which I hear is, one, from the patient point of view, where patients do believe that these are the drugs which help them improve their immunity or strength and vigor. The second thing is these drugs which are prescribed by another consultant. So again, without disrespecting the other consultant, I would reduce drugs which only I have prescribed. Few of these drugs which belong to other specialty, like bronchodilators which belong to pulmonology, the neutropil and levetiracetam which belong to neurology, I would suggest them to go talk to the concerned specialist and take their opinion in de-prescribing them. But I would suggest them, please go check, not crossing the boundaries as well. Again, unless we pay conscious attention, which is becoming challenging in the busy practice, I think if we can pay attention, we can achieve, we can de-prescribe a lot of these drugs, and I think that should be the goal. And this, if we can make an active attempt, we can achieve it. I think long monologue. These are my comments. If there's anything anybody does not accept, I would be happy to take comments from others. Thank you.
Pranit, just one question do I have? One question I have for you. When we are talking about reducing the drug or the pill burden, are we particularly talking about reducing pill burden or reducing drug burden? Because there is a difference between the two, right? Even if you are giving, let's say, a fixed dose combination, at the end of the day, the patient is still getting all these other medications. So are we kind of covering it under the carpet when we are giving a fixed dose combination for polypharmacy?
So two things here. One, definitely the reducing the drug burden. Few of those drugs which are not absolutely indicated, like for a person who has post ACS, dual antiplatelet therapy is not absolutely necessary. We can give him single antiplatelet. So that is reducing the drugs per se. And to overall improve the patient compliance and making him feel better, I personally feel that the pill burden should be reduced where patients can be comfortable. So I would try to make combinate drugs as a combination whereby patient will be comfortable and thereby improve the compliance. So that is my take on or my practice, where I would reduce the pill burden. But your point of reducing the drugs as much as possible is always there, and reducing the pill burden to overall reduce the compliance. That is my take on it.
Thank you, Praneeth. I will move on. I'm reading a chat. Yeah. So I'm reading through the comments in the chat box. Praveen sir, if you could please unmute yourself and share your thoughts, what you have been writing on the chat box regarding this patient's anti-seizure medicine. And before you say, I just want to highlight this, that, As a cardiologist, and we will ask Shankar sir also later on about his opinion, but as a cardiologist, we will never touch anti-seizure medication. Now, is it something that we should take an ownership and understand that at what point seizure prophylaxis can be stopped? Because there are at times where I have sent the patient to a neurologist with a specific question: can the anti-seizure medication be stopped? And I have been not quite successful. That is just my biased opinion towards it. So Praveen sir, what do you think about this patient?
Yeah, thank you, sir. Hope I'm audible.
Oh yes, you are audible, absolutely.
Yeah, that was a very good topic what you have chosen. And first, I'll stick to the topic. Uh, in neurology, as per se, seizure profile or prophylaxis as of now, seizure medicines are not indicated. But whenever uh, whenever we see prescriptions, we ask the patient, did you have a seizure? We always get most of the time we get the answer, no. Therefore, what I do, I go through the discharge summary. If the patient is not mine, I go through the seizure, go through the discharge summary. If there was no history of seizure and it was only for a prophylaxis, we can definitely stop the seizure medication. There are no two things about it, because even in acute stroke, seizure as a anti-seizure medication as prophylaxis are not advocated, but inadvertently they are used. The second tablet as of a nootropill. Nootropill, in fact, in many of the series, it is considered as a food, not a drug. Therefore, I don't use it, in fact. And European fort, as we all know, yeah, it may serve for some purpose, but in a long term, it's nothing. It's no use. All of the excess goes down the drain, goes in the urine. Therefore, I totally agree. A pill burden, more medicines, increasing medicines, they are the bane of today's prescriptions. And many times, as Dr. Mohandas, our mentor, puts it, his work is daily to cut down the medicine drug by drug in a prescription.
Praveen sir, quick question for you. So since I have you on this topic, uh, stroke prophylaxis medication is more commoner than what we would want, and I'm no one to comment on it, but I'm just reading out what you said, that in acute stroke also seizure prophylaxis may not be indicated if they didn't have any seizure. The problem is a lot of these patients who get intubated, who have got this some mentation issue, and we don't know whether they had absent seizures or they didn't have any seizures, and MRI shows a lot of these changes and whatnot, so they inadvertently are put on these medicine. Is there an algorithm where you can teach us about when to stop these medicines if they don't have a documented seizure, or you would make a blanket statement that if they had no documented seizure, no medicine at all? What is your thoughts on that?
Yes, very well. In this ICU settings, we keep on seeing this. Therefore, what you're talking about is the non-convulsive seizures. The patient is unconscious and the EEG picks up the seizures. Therefore, that is called as a non-convulsive seizure. Yes, if we get a documented evidence that EEG was done and EEG showed some amount of epileptiform activity, then definitely I will continue. If I don't have any evidence of that, just to be more on the safe side, I will do a EEG at this point of time and try to look for any evidence. If the evidence is not there, I will explain to the patient and I will try to stop the medicine.
And you explain to the patient just for the sake of it, or you genuinely believe the patient does not need medication?
Two things. One, uh, the most common medicine, what is anti-seizure medicine, what is being used is levetiracetam. We think it's very safe. Yes, it's safe in the manner that it does. The problem is that it has a lot of behavioral changes. Therefore, definitely not for the sake of the patient, to decrease the pill burden, I stop the tablet.
Thank you so much, sir, for your suggestion. And I invite anybody in the attendance, if you have any thoughts or questions or comments, you please write down on the chat box, just like Praveen sir did, or you raise your hand and I will get you a chance to speak up. I will ask Dr. Gauri Kulkarni, ma'am, first of all, welcome back. You have been joining after a long time. And second, I'm sure this is a topic that interests you quite a lot. The question here is, one, the strategy of reducing polypharmacy, even if that means that we may be blamed for saying that we are not doing appropriate medical care as to speak, or the scientific medical care as to speak. And second, the confidence of de-prescribing medications which have been prescribed by somebody else. Gauri ma'am.
Thank you, doctor. Thank you for inviting me. And yes, it's been a long time, but thank you. This definitely excites me as a clinician. Polypharmacy is something that I see in clinical practice very, very often. And it's usually because of the same problem, right? Multiple specialists being consulted, and because of paucity of time, maybe that there is no specific one place where all these drugs are put in one place, right? And which results in just way too many drugs that are written many a times, and or rather most of the times the drugs seem to be, if you look at it from a silo perspective, they are all right within the guidelines, but then just because there are just so many, you need to then figure out a way to make what is the most important, right? So the way I approach it is, when I'm sitting with a patient and I have like this list in front of me, I usually make a problem list, right? I call it a problem list. Like we sit with a patient and see, okay, so what is the problem list here, right? We know that there is diabetes, which is there for a long time. We know that there is hypertension. We know that there is COPD. There is arthritic problems. There is anything else, and then you kind of figure out what are the problem lists in terms of the symptom presentation. What is the patient's pain point at this point in time? And once we create a problem list, then we know what you're trying to hit at, right? Like, what are you getting there? And it is always a shared decision making, where you discuss with the patient that there could be a plus and minus to reducing the pill burden. The first question I usually ask patient is, how do they feel about just taking so many drugs, right? Like you said, most people don't like it, but then there are people who are okay with it because they think, because they get it from CGHS, or that is how they have been for a long period of time. If that is so, then explain to them what could be the issues with polypharmacy, right? Like you mentioned, we don't even know how the drugs interact, right? I have seen prescriptions where the patient has been put, say, on a ACE inhibitor both by a cardiologist and by a nephrologist. I've seen that because they did not see the two prescriptions. I mean, they did not see what each other was prescribing, right? I see prescriptions like that as well, where there are two drugs of the same class written. But most of the time I see that there are so many drugs. I take this principle of what the patient wants, what is the patient's pain point, and what is the problem list that I create with the patient, to ensure that, what is it that we are targeting at, right? For example, in this patient, looks like sugars are reasonably under control, right? I may want to look at his past reports. If the A1Cs have been more or less, within, for a 76-year-old, less than 8, it's around 7.5, 7.6. Can I actually think of cutting down of drugs and ensuring that there are regular checkups done in terms of monitoring of blood levels, to just taper down on the drugs, right? Because he's on 2,000 milligrams of metformin. I'm sure his gastric irritation must be off the roof, right? Maybe the patient is not even telling us half the story of how difficult it is for them to, when they're on so many drugs. So just looking at these drugs and figuring out what can be tapered, and with a shared decision making, where you tell the patient, see, this is a trial and error, right? You and I have to be accomplice here, right? And we work around this. Now, some things might work, some things, we might have to get back the drug on if there are so and so symptoms. So I usually, see patients very regularly. So I have patients who come back every 15 days and we review and then realize, oh, this has worked for them, or this is not working for them, and then take it ahead from there. But usually when you're cutting down on drugs, it has to be slow and steady progress. It cannot be that suddenly you take off drugs, unless it's especially unless it's irrational drug, or something, a list of drugs that are being given. But if it is rational and cutting down is required, it is only when the patient is agreeing to it and is accomplished to letting us know what happens in terms of the blood test that they will be doing on a regular basis, in terms of the symptom profile that they will be telling us if something comes up which inadvertently happens because you have cut down on a drug, like that. So it takes time, but it can be done. But there has to be definite understanding from the patient's side if we are doing this. It cannot be done otherwise.
Dr. Gauri, one question for you. As you were talking about shared decision making, an ideal scenario for a general physician or for internal medicine or somebody who is so-called being a primary care provider of that patient would be, let's say if it is for a different specialty, then the ideal scenario would be where we just pick up the phone, call up that guy and say, hey, listen, this medicine on all, this patient is on all this medication. Do you think they're absolutely needed? Or can we stop it? Now we know that these things are far from reality. That is difficult to achieve in our scenario. The second point also is, if you tell patient go and see a neurologist and ask them for this medicine, or go and see an orthopedics and ask for these medicines, the chances are that these patients, because that is also a lot of work, we have to appreciate it's a 76-year-old guy.
No, they won't do it.
Right?
Absolutely.
So what is the middle ground? Can we, do we feel ourselves entitled enough that we can say, okay, I, in my best interest, am deciding that this medicine is not indicated, so stop? Or you think that is crossing too much of boundary for us? What is your opinion?
I have done both, right? I have put the decision-making power in the patient's hand. This is my opinion. However, I am a GP. This was started by this doctor. In my opinion, this is what I feel could be done to reduce the pill count, right? I do write letters to specialists and say that this is what it is. Patient has been on many drugs. You had started on so and so drug, but also that the patient is on so many other medicines. In my opinion, maybe these can be reduced to reduce his pill count. What do you think about it? Right? I have, where patients have not been convinced by me, I have written letters where they take it, I've asked them to get me phone numbers of their consultants. I have done that, but many cases it doesn't work. Then I leave the decision making to the patient. I said, well, in my opinion, this is so and so. However, you may want to get the, say cardiologist opinion, or you get a neurologist opinion to know if this is the right thing to do. What do you think about it? And usually the patient will make a choice here or there. They will say, no, I'll go with you, versus I'll go, I don't want to go with you, I will go with my neurologist, and that's perfectly all right. If they say I'll go with you, I'll tell them that, see, this is a work in progress. This is something that we'll have to work together, which means that, you have to come back to me very often. We'll have to figure out what's happening. If you get these symptoms, you need to get back quickly. We may have to restart drugs if that's required. So this whole conversation happens there. But the decision making has to be the patient's. I can't make that decision for the patient. I can give them options.
Thank you, Dr.
That's what I feel.
Yeah, I will continue the discussion. Dr. Vamsi, if you can hear me, could you please unmute yourself? Dr. Vamsi Raju?
Hello.
Vamsi,
Am I audible?
Yeah, you are audible. I have a question for you, which actually has been posted on the chat box. The question is posted by Dr. Gautam. He asks, one question for cardiologist: is dual antiplatelet required who have drug-eluting stent for more than a year? Dr. Vamsi, first of all, your thought on today's discussion, and secondly, how do you manage dual antiplatelet in your scenario post 1 year?
Yeah, we'll usually give in post ACS patients only till 1 year. Hello.
Yeah, please continue. I can hear
you. Yeah, ideally guidelines wise, after drug-eluting stents, it is not ideally indicated after after 1 year. If any further incidents of other neurological or any cardiac event, then only we'll prescribe dual antiplatelets. But routinely, so many patients, because of high risk of coronary events, so many patients are being continued with dual antiplatelets.
This is a very significant dilemma that we have, and I have seen it practiced more frequently than not. When we go and ask every cardiologist that dual antiplatelet duration, and majority of them would say to stop at 1 year. And then the second question we ask, in your practice, what percentage of your patients are taking dual antiplatelet for more than a year? And the answer mostly comes 80% or 90%. So while we all write the answer in the exam that we should stop at 1 year, in clinical practice, it never gets stopped at 1 year. That's a significant dilemma that we have. Dr. Vamsi, any thoughts on that? Why that happens?
Yeah. One reason, in my view, if I give as a dual antiplatelets, I usually give as separate only, not like gold preparation of combining two dual antiplatelets. Because if he misses one tablet, another antiplatelet will be there to safeguard. So that's why one I will combine with statin and another I will give separately, because that will, even if he misses one tablet, another will go. That is my strategy in giving dual antiplatelets. Otherwise, if he is very strict and he is very compliant with medication, I may consider single also.
Thank you, Dr. Vamsi. I think for antiplatelets, you make a very reasonable point that giving separately these medications may actually be helpful in some regard, where if they miss one tablet, at least they don't miss the entire thing. That is actually the entire discussion of fixed dose combination or FDC versus individual, that while FDC makes pill burden less, they put you at a higher risk of missing the medications in case if you miss a single tablet. That's a very relevant question. Another question which is asked in the chat box, and I will ask Vrinda. Vrinda is an endocrinologist. I'll ask Vrinda for her opinion about this. One more question which is asked. Dr. Gautam asks, as regard to diabetes, once the patient gets twice a day insulin, the oral medications can be stopped, maybe other than metformin. And then he talks about DAPA and all this. So Vrinda, my question is, we are talking about a 76-year-old guy, sugar reasonably controlled. He has some cardiac issue. We all are looking at, oh, I'm just writing 4 medications, but the patient ends up getting 16 or 20. What is your thought? Once the patient goes on insulin, can we reduce the oral hypoglycemics altogether? Or they all have synergistic effect where we should give all of them? We are talking about a 76-year-old guy whom we are trying to count how many tablets the guy is taking. Vrinda.
Hi, good evening, everyone. So very appropriately, I think the pill burden needs to come down for this patient, particularly for this patient. If a patient is on twice a day insulin, I usually look at, say things which would determine my need for ongoing insulin therapy. So if patient has had diabetes for a very long time, I know that, some beta cell failure has probably ensued over time. And if I'm certain that this patient is going to be requiring insulin twice a day or 3 times a day, then I definitely cut down on the oral anti-hypoglycemic agent for this patient. Metformin is an insulin sensitizer. So, sometimes to, kind of keep the insulin doses down, I would, use metformin in the background. But medications like sulfonylureas, if a patient is requiring insulin, then using insulin secretagogues usually does not meet much of a practical sense to say. So I would cut down on sulfonylureas. DPP4 inhibitors, same thing, because of their mechanism of action, I may cut down. Medications like you mentioned voglibos. So again, minimalistic difference to the patient in terms of blood sugar reduction, especially the patient is requiring insulin. So I think there are multiple avenues, multiple ways, I think, with which we can actually reduce the pill burden for the patient. Now coming to SGLT2 inhibitors, I think in the context of the information that we have regarding these medications, with their effect on cardiovascular disease and CKD. So there I may actually, if because of the complementary mechanism of action in terms of anti-hypoglycemic efficacy also, but if there is an ongoing need to say continue dapagliflozin, again I may consider it. But for the most part, I think if a patient is on insulin, there is a good way that you can decrease the anti-diabetic medications, oral anti-diabetic medications for this patient. And if pill burden becomes a concern, there are many patients who'd come to me and say, "Madam, I'm taking so many medications." I've actually stopped their metformin also. I've stopped their dapagliflozin also, if it's okay with the cardiologist. So certainly, I think there is a way to improve the medication list for the patient. Anoop.
Thank you, Brinda. I don't think we have a nephrologist in our attendance today. If there is any nephrologist, could you please raise your hand? Shankar sir, I am going to ask your opinion about these kind of scenarios, and particularly, how much do you think general physicians or medicine doctors like yourself stretch and say that I need to intervene on the number of tablets that the guy is taking? At what point you will take the charge in your control and say that is enough, I need to stop these medicines? Or you think with these kind of comorbidities, these patients, they end up taking these many tablets, there is not a big deal about it? Shankar sir.
Good evening to all. As a physician and a geriatrician, we will have a comprehensive approach with a core team and extended team and specialists and super specialists. And definitely here the patient, 76-year-old male with multiple clinical conditions, disease conditions, so multimorbidity, what we say. So when we confront such patients, then we go for, as asked also, medical reconciliation, where we will verify and clarify and ultimately document what are the medications he is taking, what can be dropped. And already he is on more than 16 medications. So if more than 5 medications are there, it comes under polypharmacy. And when multiple drugs the patient is on, the medication metabolism is often impaired because of reduced GFR in the elderly people and reduced hepatic clearance, and as also lean body mass also associated with the elderly frail individuals. So these are all will land, ultimately the patient lands in with adverse drug reactions, and so drug to drug interactions will be there. So the good prescriber, good doctor is not only prescribing the medication, but one component of the prescribing medication is so de-prescribing. So where we can tape what are the inappropriate medications are there in this prescription, we can drop them, we can taper them and stop them. So there are steps of de-prescribing also there. So coming to the patient index proper, as Dr. Urunda had told the same, we can reduce the pill burden. Here there is no need of oglibos. So if at all a patient is on vildagliptin, so now at the same price we have got a very good drugs are there, linagliptin and sitagliptin. But sitagliptin, here the patient, the CKD, 1.3 to 1.5 serum creatinine, it comes to eGFR 48 ml to 57 ml per minute. So he will be graded as a stage 3A. So here we can continue the metformin, but half the dosage, I instead of 2000, we can give 1000 milligrams, and instead of vildagliptin, I will switch over, or if pill burden is there, then we can drop that. Then dapagliflozin, it has got a cardiorenal safety, so definitely dapa has to be continued. The second, coming to the coronary artery disease and post PCI, he can be on a single antiplatelet agent. If the patient has got dyspeptic symptoms, he can be on clopidogrel. If there are no dyspeptic symptoms, he can continue the aspirin and we can drop clopidogrel. But earlier we have discussed many times that when we give a dual antiplatelet, at least one antiplatelet would work because of the manufacturing reasons. Then coming to the so type 2 diabetes, as Dr. Runda told, I agree with her. And dual and single antiplatelet agent, and the left ventricular ejection fraction is 45%. So he comes under heart failure with the mid-range ejection fraction. So here, the already patient is on ARB and metoprolol also there, but patient has got a COPD. So here we can reduce or we can stop metoprolol, though it is a little beneficial in coronary artery disease and heart failure. But regarding pill burden and the COPD, keeping in view, we can reduce it to 25 milligrams. Then, so patient is on a COPD. Patient is a case of a COPD. That means probably is a ex-smoker or presently is a smoker, chronic smoker. I don't know, but COPD and bronchial asthma are different obstructive airway diseases. So when it is a COPD, then foracort we don't, unless there are acute exacerbations, we don't give foracort. That is a budesonide and formoterol, where steroids are there, because the elderly person is prone to get pneumonia and all. So we give LABA-LAMA, that is a long-acting beta agonist and long-acting muscarinic agent, glycohale F, or the formoterol and tiotropium combination will be available, so that can be given. And acebrophylline, that is the ebiphylline, can be withdrawn. Coming to the CKD, as already mentioned, so he comes under stage 3A. We at present, I don't think there is a need for sodium bicarbonate nodosis, unless he goes into the stage 4, there where the metabolic acidosis is documented, we put them on a sodium bicarbonate. And coming to the BPH, brain prostatic hypertrophy, he has got only grade 1 prostatomegaly. Unless he has got a LUTS, that is a lower urinary tract symptoms, like nocturia, increased frequency of urine, or any polyuria, that is frequency of urine and nocturia is there, then incontinence. If these symptoms are there, then we give low dose silodosin, 4 milligrams only we give. We don't give dutasteride, that is a alpha reductase inhibitor. That is because if you combine these two, there will be postural hypotension. Already patient is having his low BP is there, 112 by 68. So postural hypotension is a side effect with the this anti-prostatic medication. They are alpha blockers. So I give only, if at all the patient has got a LUTS, that is a lower urinary tract symptoms are there. With this mildly enlarged the prostate, we can give only half the dosage of silodosin. That is sufficient enough. Then coming to the osteoarthritis, the patient is on some glucosamine. They are nutritional supplements. We can, there is no indication for these nutritional supplements in this case, because already pill burden is there, drug interactions will be there, and there is no advantage of giving these nutritional supplements in case of osteoarthritis, like chondroitin, glucosamine, diacerine, and all. So vitamin D and all. So here, if at all the patient has got knee pain is there, we can give him acetaminophen, that is a paracetamol, topical. We can give a topical analgesics, capsaicin, and that can be given. And other non-pharmacological methods like knee braces, the walking aids, tents, and all other things can be given to combat osteoarthritis in this case. So the patient has got watershed infarcts earlier. Patient as a prophylaxis, I don't think there is no need of anti-seizure medication in this case. And there is no need of nootropill, that is a paracetam. We can withdraw these two drugs, but levetiracetam, we can taper and stop within 1 or 2 months. So regarding regarding all these conditions like type 2 diabetes, hypertension, CAD with LVF, post PCI, CKD, COPD, PPH, and osteoarthritis both knees. So with this, I can single antiplatelet agent, we can drop one, and then metoprolol can be reduced, tapered to a minimum effective dosage. The Silodol D can be dropped, no doses, and cellopatric, that is prebiotic or probiotic, not necessary now. The esaprophylline, that is ebiphylline, can be dropped. Then the chondroitin or the glucosamine can be withdrawn in this case. Levetiracetam can be withdrawn, and nootropill also can be dropped. So Neurobion Fort also, there is not much use in this case. So with this, we can reduce many, we can withdraw many drugs in this case, and effective drugs for the diabetes, hypertension, CAD, LVF, and COPD. We can continue the medication. So what mentioned about. Thank you, one and all.
Thank you, Shankar sir. I will invite Somaraju sir for his opinion on today's discussion and whatever we have discussed so far.
Thank you, Anoop, and good evening to everybody. Dr. Anoop, if you recall, the last time we were talking about proton pump inhibitors and Helicobacter pylori investigation and all that in the last one of the last sessions. I
Yes,
did
sir.
point out the first requirement for you to do in this patient is address the polypharmacy and stop metformin. Do you recall?
Yes, sir, absolutely.
Yeah, then only think of investigating further for Helicobacter pylori and all that. I stick to that. I do that as my routine practice, and it's important. Many of the issues are already discussed, except I have to tell you, while polypharmacy you are talking about, polyspecialties you are talking about also. But there is one treating clinician, one specialist, or include one physician in the system. As a rule, I follow the principle of involving a physician in almost all my patients. They are the ones who help us in making these decisions when they are involved. And say many of the other issues related to polypharmacy are already discussed, except that in the whole system, the issue is not whether anyone agrees or disagrees. There is a treating clinician. They will be the ones who will make the final decision. I don't agree with the concept so-called American medicine. We are importing and we have problems with it. Leave it to the patient. The patient won't know. And many times you have to guide them. Thank you.
Sir, I have a question for you. We all are talking about, and this is what I put it in my prologue early on, that we all are taught and learned that diseases need to be handled in a certain way. What we are not taught is how diseases should be handled when there are so many of them in one particular patient, particularly during extremes of age. So, like what Praneeth was mentioning, beta blocker and ARB in this patient is quite relevant. Antiplatelet 1 and statins are quite relevant in this patient. My question to you is it there a point where we say that no, it is not relevant in this particular patient? He does not need to be on these medications. He can very well lead a normal life without these also, whatever life at his age with his comorbidities. Are we under treating these patients? Or you think I'm stepping out of my boundaries, that we should respect whatever the treatment modalities has been described? I hope I got my question clear.
I'm glad you asked this question, Anoop. It's very important to realize that so-called guidelines, so-called evidence-based medicine don't address your individual patient's problems. A 76-year-old person, when you talk about previous angioplasty, a post-angioplasty again is not a single disease. Whether it is a multiple stents, long segment stents, distal disease or multivessel disease, or location of the stents, and other issues have to be taken into consideration. Most important issue is the patient's age. Whether you are dealing with a 50-year-old person or a 76-year-old person with other issues I mentioned, the subsets of so-called post-angioplasty is not a single disease. So to try to think that they are single disease and think that you stop it at 6 months or 1 year, we are oversimplifying. Mind you, guidelines won't help you. You have to individualize, you have to take that responsibility and intuition and also knowledge into individual patients' requirements. Thank you.
Thank you so much, sir. It is 8:03, so I will start concluding the session. If anybody has got any particular comments or question, please feel free to put it in the chat box. And while you do so, I'll ask Praneeth for his closing comments.
Yeah, no, a very relevant topic. Though with hesitancy, I'm glad we did discuss about this topic, and I'm happy that we had a good discussion, and I'm glad to know that many of them share the same thought process on polypharmacy. As you rightly pointed out, the difference between what we say versus what we practice is always there, and I believe unless and until we do not discuss these things, the action is not going to happen. And I'm glad we discussed about this thing, and everybody has that intention at least that polypharmacy should be reduced. And I believe with this discussion that we had today, that is a seed for everybody to pay attention to the number of drugs that the patient is receiving, and pondering on creating an opportunity where if possible, some of these drugs, if they are not truly indicated, can be cut down. And I believe talking to other colleagues as well, when in doubt, taking their opinion and asking them for suggestion that whether these drugs are really needed. And I believe if we holistically work together, we can definitely reduce this pill burden. And more importantly, bringing patient into the center, what patient needs, reassuring them that most of these drugs are not necessary, and these are only few things which are important, and these are the things which you need to be compliant. And when in doubt, always come back and discuss and get it clarified. And I believe if we can put this thought process every time that we put our pen down the paper, we can definitely do more justice to the patient, and thereby reduce this polypharmacy. I think this is the closing remarks from my end, Anoop.
Shankar sir, you have anything to add?
Regarding patient is on atorvastatin 40 milligrams, I don't think he needs such high dosage statin. So we can reduce it to 10 milligrams. Suppose if he doesn't achieve the goals, then we can add ezetimibe. So we can reduce the atorvastatin dosage here. And one more thing, I would like to bring it to the notice of August audience. So these two things will be available everywhere in the pharmacology book or in the search engines. Stop and start criteria, where what are the inappropriate medications and what are the right medications. So the lists are there, so that we have to go through the stop or start criteria. And the American Geriatric Society, the Beers criteria, where the potentially inappropriate medications usage in the older adults more than 65 years of age, the list is there. It is updated also in the 2022. So one has to go through what are the medications to be prescribed, what are the side effects, what are the indications, what are the recommendations, and all. So these two things, stop or start criteria and the Beers criteria. And one more word regarding the prescribing cascade. We come across when we go through this polypharmacy, when a new medicine is prescribed to treat an adverse reaction. For example, a patient has got a dementia, where we give cholinesterase, donepezil, that causes incontinence of urine. So thinking that incontinence patient has got, it is a new condition or a new disease condition, and we give some anticholinergic agents to combat this incontinence. So this is known as a prescribing cascade. So before we give any medication, whether it is due to the drug or not, we should find it out, drug related or not, adverse drug events or not. Then we should, when we rule out that adverse drug event, then only we should treat it as a disease condition. Otherwise, go on treating adverse events also. So that becomes a big list of medications. Thank you, one and all.
Thank you, Shankar sir. Thank you, Praneeth, and thank you all of you for attending today's session and sparing your hour discussing today's topic. As most of you know, we do these sessions every Wednesday starting 7 p.m. The link to join is the same, so you can use the same link to join future sessions as well. A lot of the old episodes are recorded and they have been uploaded on YouTube and Castbox. You can use your dead time to listen to those as well. Thank you all. Good night, and hopefully I'll see you next Wednesday as well. Take care, guys.